Welcome back everyone to another episode of Ortho Study Tool. My name's Tony DeBarno. Today I want to talk about calcaneus fractures. I was originally planning on talking about pelvic ring fractures, but I actually saw an interesting calcaneus case today that I want to discuss toward the end of the video. And just before we begin, I hope that this series serves as a good study tool for any auditioning orthopedic medical students or residents, and I'm hoping that these videos can serve as almost a pathoma for ortho related subjects. So hope you enjoyed the videos. Let's get started. So to start out, let's just review the relevant anatomy of the calcaneus. On the left, you're looking at a view of the calcaneus from the posterior side. Some things you want to pay attention to are the tuberosity. This is the region where your Achilles tendon attaches, your posterior, middle, and anterior facets. These are the three articulating surfaces of the subtalar joint. And specifically, the posterior facet is the area you want to pay attention to because it's the main weight-bearing surface of the subtalar joint, and there's a lot of other relevant structures that are close by in relation to this. That including the sustentaculum tali, which is this medial projection here. The sinus tarsi, which runs between the posterior and middle facets, where the artery of the tarsal sinus passes. Sinus tarsi syndrome can result from compression of this artery in overpronated or flat feet. That's just a side note. Also, in relation to the posterior facet, your flexor hallucis longus tendon passes in this region and under the sustentaculum tali. We will talk about injuries, iatrogenic injuries that can arise from misplacing screws during fixation of the calcaneus. You also want to pay attention to the anterior process, which connects the calcaneus navicular and cuboid together via the bifurcate ligament, and fractures in this area result from stress put on the calcaneus by the bifurcate ligament as it's stretched. And this radiograph just helps you visualize the calcaneus relative to the other tarsal bones. So you have your calcaneus, your talus, your subtalar joint, and the tarsal sinus here, and then you have your navicular and cuboid, and then your cuneiforms. All right. So continuing with the introduction, calcaneal fractures are the most frequent tarsal fractures. Additionally, extension in the calcaneo-cuboid joint occurs greater than 60% of the time. So more often than not, you're going to see this, which also means that more often than not, the patient's going to require operative fixation to deal with their injury. You also want to look out for contralateral calcaneus and or vertebral fractures, as these occur about 10% of the time. This is something you might get asked as an auditioning student. If you ever see a calcaneus fracture, what additional images do you want to get? You always want to look at the spine, particularly the lumbar spine and the contralateral side, just to rule out additional fractures that you might not notice initially. These injuries are common because the high energy nature of calcaneus fractures, and because you often see these in cases where people are jumping off buildings or falling from high heights and landing on both feet simultaneously. There's also a very high complication rate associated with calcaneus fractures due to the poor vascularity and also the poor soft tissues located around this area, as well as other factors that we'll discuss, the complex anatomy in that area and so on. We'll discuss the complications in more detail toward the end of the video. So some imaging modalities that you can use to better characterize calcaneus fractures are AP, lateral, and oblique x-rays. These are standard x-rays you'll get for almost any type of fracture, so we won't go into that any further. Additionally, special images, special x-rays you might want to take are your Broden view, which you take with the ankle in neutral dorsiflexion and 45 degrees internal rotation. And then you take sequential x-rays at 40, 30, 20, and 10 degrees cephalad from neutral to visualize the posterior facet. Again, you are concerned about your posterior facet because this is your main weight-bearing surface of the subtalar joint. I wasn't able to find a great open source view, Broden view, but you can find images online if you're curious to see what these look like. And then your Harris view is another view where you place the foot in maximal dorsiflexion and angle the x-ray beam 45 degrees. That's this view in the top right hand corner. A lot of times this view will be taken intraoperatively. It allows you to visualize the calcaneus from the plantar surface and see the contours of the posterior aspect of the calcaneus and the tuberosity. So that's your Harris view. Additionally, your gold standard for imaging of calcaneus fractures is CT. That's for two reasons. It helps with operative planning, and it also helps classify calcaneus fractures. Your classification for calcaneus fractures is based on a specific view of your CT. We'll get into that in a little bit more detail. And then MRIs are used to diagnose calcaneal stress fractures that are not able to be visualized with the above imaging. That's pretty much the only time where you'll need an MRI to diagnose a calcaneus fracture. Moving on, there are some additional measurements that you can take on your lateral view of the calcaneus that help better characterize the injury you're dealing with. So first is your Bowler angle. This angle is established by connecting a line from the superiormost portions or intersecting lines, first from the superior portions of the anterior facet to the posterior facet, and then the superiormost portion of the tuberosity to the superiormost portion of the posterior facet. You take this angle here, and normal is between 20 and 40 degrees. So what does this help us determine? This helps us determine if you're dealing with some collapse of the posterior facet. How does that work? Well, if you have a decreased Bowler angle, meaning it's less than 20 degrees, if you try to visualize that, that means that this point is down here. So your line would be flat, the angle would be narrower. So less than 20 degrees is a sign of collapse of the posterior facet, often seen in depressed calcaneus fractures. Another measurement that you can take is the critical or crucial angle of Gissane. I've heard it said both ways. And this is taken by drawing a line basically in the area of the sinus tarsi, and you're drawing it from the deepest portion to the superiormost portion of the anterior facet here, and then you're drawing another line parallel to this progression up to the posterior facet here. Normal is between 120 and 140 degrees. So I think it's easy to remember these numbers. Remembering the names can be challenging, but remembering the numbers is easy because you just add a 1 in front of this for the angle of Gissane. Interpreting it can be a little bit trickier, so let's go through that. So for the angle of Gissane, if you're dealing with a posterior facet that is depressed, your angle will actually be increased because, again, if your posterior facet is collapsed, it's going to be down here. So you're going to draw a line instead of vertical like this, you're going to be drawing a line like this, which would increase your angle. Okay, so for Bowler angle, decreased angle indicates a depressed posterior facet. For the angle of Gissane, increased angle is a sign of a depressed posterior facet. So those are just some additional measurements you can take when you're trying to assess if there is a calcaneus fracture and to what extent the facet is collapsed. All right, so let's talk about the classifications of calcaneus fractures. You can either be dealing with extra-articular calcaneus fractures. These are fractures not involving any of those three facets, anterior, middle, or posterior. These only occur about a quarter of the time. The other 3/4 of the time, you'll be seeing or dealing with intra-articular fractures that do involve at least one of those three facets. But to talk a little bit more in detail about the extra-articular fractures that you'll commonly see, one type that you might see are the anterior process avulsion fractures. And we talked about these earlier. These occur because your bifurcate ligament that connects your calcaneus anteriorly to your navicular and cuboid bones comes under tension and pulls and avulses the anterior process of the calcaneus. Another type of extra-articular fracture that you can see is sustentaculum tali fractures. That's the medial projection of the calcaneus. And these are only extra-articular if they do not involve the surrounding facet joints. And then finally, you can see extra-articular fractures that occur as the result of the Achilles tendon pulling and causing avulsion of the tuberosity where they attach posteriorly on the calcaneus. So those are extra-articular fractures of the calcaneus. There are also two different classification systems that describe intra-articular fractures of the calcaneus, and we'll look at those in more detail. So first we'll look at the Essex-Lopresti classification. This classification describes fracture patterns where you have two fracture lines. You have a primary fracture line that occurs obliquely through the posterior facet. And then you have a secondary fracture line that runs in one or two planes, resulting in two potentially different types of fractures. So the first plane that it can run in results in a joint depression fracture. And this is what we are looking for with a decreased Bowler angle or an increased angle of Gissane. And this secondary fracture line that causes this type of fracture is located behind the posterior facet. So you can see here you have a fracture line posterior to the posterior facet causing a joint depression. So this is your joint depression. If we look at the Bowler angle for this, we connect the superiormost portion of the calcaneus anteriorly to the superiormost portion of the posterior facet, and then the superiormost portion of the tuberosity. This line is pretty flat. It's definitely less than 20 degrees. So we know that this is a joint depression type fracture with a collapsed posterior facet. The other possibility, if the secondary fracture line runs in the axial plane beneath the facet, the posterior facet, and exits the joint or the calcaneus posteriorly, is a tongue type fracture. That's what we see here. You can see running in the axial plane beneath the posterior facet and exiting posteriorly, you have a fracture, a secondary fracture line that causes a tongue type fracture. And the name, I'm assuming it was derived because the portion of bone that sticks up looks like a tongue. All right, so that's your Essex-Lopresti classification. Again, the main two types of fractures you'll see are joint depression fractures or tongue type fractures. And these occur as a result of the direction the secondary fracture line runs in. The primary fracture line is always through the posterior facet. Another classification that's commonly used and probably more often used is the Sanders classification. A key thing to note, something that's easy to overlook the first couple times you study the Sanders classification, is that this classification is based on the number of articular fragments seen on a coronal CT image. That's key, coronal CT image at the widest point of the posterior facet. So we've said posterior facet a number of times today. In addition to it being the main weight-bearing surface of the subtalar joint, it's also, a key component of both these fracture classifications. But don't get too distracted by that, because you want to remember you're looking at a coronal CT image to classify with the Sanders classification. There are 4 types of fractures described by the Sanders classification. Type 1, any non-displaced posterior facet fracture. So if it's non-displaced type 1, that's pretty easy to remember. Type 2 is one fracture line in the posterior facet. Another way people remember this is one fracture line results in 2 fragments. So type 2, 2 fragments. If I had to say what we're looking at here, this is probably a type 2. You see one fracture line, 2 fragments. Type 3 fractures have 2 fracture lines, so they have 3 fragments. Again, nice little way association there that helps you remember. Type 2, 2 fragments. Type 3, 3 fragments. And then you just reduce it if you're dealing with fracture lines. And then finally, type 4 in the Sanders classification describes comminuted fractures. It's implied that when I say comminuted, this is more than 3 fragments. So there's 3 fracture lines, so there's 4 or more fragments. So for quick review, type 1, non-displaced. Type 2, 2 fragments. Type 3, 3 fragments. Type 4, 4 or more fragments. So let's discuss treatment of calcaneus fractures. We're not going to go into too much detail, but I do want to discuss it to some degree. First, we'll talk about non-operative treatment of calcaneus fractures. This is usually not possible just because you're going to be dealing with calcaneus fractures that don't have these characteristics more often than not, just due to the high energy nature of the injury. So if you're just dealing with a stress fracture, which you may or may not have used an MRI to diagnose, you're just going to do cast immobilization for 6 weeks. You're going to extend the period of cast immobilization to 10 to 12 weeks if you're dealing with any one of these 4 situations. You're dealing with small, extra-articular, non-displaced fractures with an intact Achilles tendon. There are specific measurements and criteria that describe small and non-displaced. I think this is less than 1 millimeter and this is less than 2 millimeters. But just remember, small, extra-articular, non-displaced with an intact Achilles tendon. It's common sense, but it's good to see these things just to remind yourself. Implied with non-displaced, that also includes Sanders type 1 because those are non-displaced posterior facet fractures. Isolated non-displaced posterior facet fractures. You also can cast immobilize anterior process fractures with less than 25% involvement of the calcaneocuboid joint. But remember, we said involvement of the calcaneocuboid joint can occur as often as 63% of the time in calcaneus fractures. So this is something you're going to want to look at if you're on the fence about operative versus non-operative treatment very closely, because this is not an uncommon occurrence. And then finally, if you're dealing with patients who have medical comorbidities that put them at risk of complications, like smokers, diabetic patients, patients with peripheral vascular disease, you might want to be more conservative and just cast immobilize them for 10 to 12 weeks. And then before I move on and forget, this is just another image that helps you visualize what your bular angle is. So I just wanted to throw this in here as well. As far as operative treatment goes, there's a couple of options that you can consider. First is closed reduction percutaneous pinning. The situations where you might consider doing this are minimally displaced tongue-type fractures. So remember, we'll go back here just to quickly look at it. These are your tongue-type fractures. I wouldn't say that this one is minimally displaced, and so this would probably require operative treatment. But if it was just minimally displaced, you could end up doing a CRPP instead of like a ORIF. In addition, you can also do CRPP for large extra-articular fractures, large being greater than 1 millimeter, I believe, is the cutoff. For open reduction internal fixation, these are the situations where you're going to want to take that route. Any type of displaced tongue type fracture like we just saw, any large greater than 1 millimeter, extra articular displaced greater than 2 millimeters without intact Achilles tendon. These are all situations that would require ORIF. Sanders type 2 and type 3 fractures with 2 fragments or 3 fragments. anterior process fractures with greater than 25% of involvement of the calcaneocuboid joint, which makes sense, just the opposite of what we previously said regarding non-operative treatment. And then you would also consider doing ORIF if you have a displaced fracture of the sustentaculum tali, which is that medial projection. Your third option for operative treatment is primary subtalar arthrodesis. This is where you're just doing a subtalar fusion, basically, and you'd want to do this to stabilize really comminuted fractures like Sanders type 4 fractures. And then this image I threw in here just to help you visualize the bifurcate ligament. It's this white sheet right here. Here's your cuboid, here's your navicular, here's your calcaneus, and it's just connecting those three structures together. So this is what causes avulsion fractures of the anterior process when it's under tension. Lastly, we'll discuss complications of calcaneus fractures. Again, wound problems are significant in calcaneus fractures between 10 and 25% of the time. Of note, regarding wound problems, in addition to post-op wound issues, pre-operatively, if you're dealing with calcaneus fractures, particularly something like a tongue type fracture that's putting the soft tissues in that area under tension and potentially causing tenting of the skin, you'll in those situations you should consider that an orthopedic emergency, because those soft tissues are going to deteriorate rapidly in as little as between 1 to 6 hours. So you want to deal with that. You want to get an adequate reduction and definitively fix the issue in those situations when the soft tissues are being compromised like that. That's just a note that you want to remember if you ever see, a tongue-tight fracture or any other calcaneus fracture. You want to make sure that you're preserving the soft tissues that are under tension. Additionally, subtalar arthritis is a big issue, and it's a consideration if you're deciding in really complicated fractures, if you want to perform ORIF or if you want to do a subtalar fusion. As I mentioned before, damage to the flexor hallucis longus tendon is common to its location relative to the posterior facet and the sustentaculum tali, and these can often be iatrogenic as screws are projecting posteromedially through the posterior facet. Finally, compartment syndrome is fairly common in calcaneus fractures, likely due to the high energy injury combined with the tightly packed area and poor vascularity in that region. You can see clawing of the digits in this case as a long-term consequence. And then malunion is also a very big complication. And this is something I want to talk about related to the case that I saw today. It was a pretty interesting case. The patient had what I assume was a Sanders type 4 like fracture, pretty complicated as a result of a fall from significant height. She jumped out of a building and fractured her calcaneus of her right foot, and then also suffered a pretty significant pilon fracture of her left ankle. But what I wanted to talk about is if you develop a malunion, which is described as like a loss of height, widening, and subsequent lateral impingement. What you can do to help correct this is a distraction bone block subtalar arthrodesis. So in the case we saw today, basically what you're doing in this situation is you're going back in, you're removing a lot of the fibrous tissue and the portion of the subtalar joint that was that didn't heal properly. You're removing that, and then you're taking a iliac crest bone graft, and then you're actually taking those bone grafts and you're basically wedging those back in to the area of the subtalar joint that was fibrous and degenerative that you removed, to reestablish the height and to correct any other malalignment or lateral impingement. It was a pretty interesting case. So I just wanted to mention that because I haven't seen these type of cases before, and from my interpretation, they're not very common, especially if you're not dealing with foot and ankle surgeon or someone like that. So that's my final note. I hope this video was helpful for you guys. Again, feel free to ask any questions or make any comments. Your feedback is very helpful. I'll be posting these videos every day, so I hope they're helpful and I hope you guys enjoy them. But for now, guys, have a good night.